takes a moment to get going.
So they'll see the slides and then I'll be in the corner. Is that how it works? Or is it side by side? Okay.
Yep, so we are good to go now. Alrighty, everyone. So thank you so much for joining us. Welcome to the 2023 PI conference. My name is Rebecca Russ, and I will be your moderator for today's session, Women's Health and PI. And I'm so excited to welcome Dr. Lugar, who will be presenting on this topic to everyone today. So just as a reminder, there will be time for questions at the end of the presentation. So please go ahead and submit any questions you might have throughout the session to the Q&A section of your platform. Today's session is sponsored by CSL Behring, and we are very grateful for their ongoing support of our education and learning opportunities. So Patricia Lugar, MD, received her medical degree from the University at Buffalo School of Medicine and Biomedical Sciences in Buffalo, New York. Dr. Lugar went on to complete her internship and residency at Northwestern McGaw Memorial Hospital in Chicago, Illinois. Prior to her research fellowship in immunology, Dr. Lugar was a clinical fellow in allergy and immunology at the National Institute of Health. Dr. Lugar currently works at Duke University Medical Center, where she is an associate professor of medicine and associate professor of pediatrics and section chief of allergy and immunology. She's the medical director of the Medication Desensitization Program at Duke University Hospital and a medical school course director in allergy and clinical immunology. Her clinical and science research goals include studying rare diseases with a focus on common variable immune deficiency. She is conducting clinical trials in adult onset immune deficiency, systemic mastocytosis, and hereditary angioedema. She hopes to better understand how to treat many aspects of disease manifestations in rare diseases and implement novel therapeutics. So thank you so much for joining us, Dr. Lugar. It's just great to have you here to talk about this really important topic to our community. So with that, I will pass it over to you.
Great, thank you so much for that introduction, and hello to everyone this afternoon. Thank you for joining in. I hope this presentation is informative. I hope we all learn a lot together, and I can't wait to hear your questions. We will be talking about women's health and PI, and we'll talk about PI as primary immune deficiency and its disorders, and we'll use that as an abbreviation, focusing on women's health through the reproductive years, fertility, pregnancy, and we'll go beyond. So, let's see if I can advance. Aha, here we go. Yes, okay, a little delay. So one of the reasons why I've been passionate about women's health issues and primary immune deficiencies, because when we are managing our patients in clinic, we don't have a lot of resources. We don't have a book or journal articles. There's just not a lot of information that we can go to help our patients. It's just really a subject that's underrepresented in the literature. Now, when we think about some sources about how we find information, it's usually from our experience, many patients over decades being treated, and we do what's called retrospective studies, where we ask women, okay, what happened to you well beyond the reproductive years? What happened with your pregnancies? Did you have issues with fertility? And also in large institutions, you know, we've been caring for our patients that have been following for many decades. We can do chart reviews, and we can do surveys, we can do chart reviews, and that's what we're going to be talking about today. A lot of the data that we have is really coming from these resources. And so we'll dive in. So we'll talk about what is known about PI and the effects on puberty, fertility, gravity, which is a word that means the ability to conceive and just the being pregnant or a pregnancy, and then the outcomes of those pregnancies, as well as talk about the management of PI during pregnancy and any effects on newborns and what we can learn about how immunoglobulin replacement can affect newborn antibody levels. And then we'll shift over to what happens as we get out of those reproductive years and what things can we expect to follow with our health as women during those times. So this is a very brief overview, but in this conference in particular, we'll learn about different types of immune deficiencies. There's so many named disorders, but in broad categories, we think about cellular immune defects and antibody defects. I'm not going to go through them, but when we talk about women's health issues in PI, we're really encompassing all that is known about immune deficiencies. And when we're talking about the cellular defects, such as severe combined immune deficiency, or SCID, or chronic granulomatous disease, CGD, and many other disorders, there are really no published reports, and they tend to be very, very rare. So you're not going to find large numbers, and I couldn't find any really measurable studies or case reports to really discuss today. But we do know that many treatments are employed to manage the immune deficiency, particularly in the cellular immune deficiencies. These could be stem cell transplantation, bone marrow transplantation, sometimes medications that are chemotherapy types of medications or immune suppression. So that those treatments, we definitely know the effects that certain treatments can have a role in fertility and reproductive capacity. And so we probably know more about that than we have any information on specific genetic disorders and cellular immune defects. So oftentimes those conversations are really getting into what treatments have been employed. And the same thing is true for antibody deficiencies. Although we don't have any published data that can tell us these specific antibody disorders can have these effects on our reproduction, we can certainly look at those studies we talked about, case reports and surveys and retrospective studies. But when we're thinking about how are these patients being managed, what types of medications have they been exposed to, then we can provide much more information on, well, these medications may have these outcomes. So just the immune deficiencies, there's really not a lot. We know a lot about how we manage these PI disorders and the effects they can have. So I'm really focusing just on what is known about patients walking around with PI and what happens with their fertility and their pregnancy outcomes, and not getting into the nitty-gritty about treatment. But I'm happy to sort of field some of those questions if questions come up as we go through this presentation. So as I said, there's nothing specific we know about an effect on specifically on puberty or on pregnancy. We talked about puberty and fertility. Now on pregnancy itself, again, really relates to what exposures, medications, and treatments you might have experienced because of the PI diagnosis. I think there's a little delay, so if I jump ahead too fast, it's because it's catching up. Oops, sorry about that. Okay, so let's talk about the largest survey that was conducted. Was actually conducted by the IDF, and the IDF community members responded to this survey. And we're going to be talking about pregnancy. It's the largest source of published data where we understand pregnancy and PI. And so just to get our feet wet into what the population that responded looks like, because we'll be talking about this throughout as we move forward, we see that a large number of respondents were in their childbearing years. So between the ages of 18 to 44, reproductive capacity is robust, and a lot of pregnancies occur during this period of our lives. During the ages of 45 and 54, certainly reproductive capacity has decreased. So we see that there was a good portion of respondents that were sort of in different stages of life and different stages of reproductive capacity. That means that There are some respondents that had past reproductive capacity and a number of respondents that were in the middle of their childbearing years and probably planning their families when they were responding to this survey. So what did we learn? In addition, the majority, which is not a surprise, but the majority of the respondents, in addition to being represented over a large age range, also the majority have a diagnosis in PI that's an antibody deficiency. We'll see the top 5 most common diagnoses are antibody deficiencies: common variable immune deficiency, hypogammaglobulinemia, etc. We see SCID, which is severe combined immune deficiency, was 1%, and that's in the cellular disorders, but even below their agammaglobulinemia and hyper-IgM are also antibody deficiencies. So we're really talking about a large number of the respondents, over 90% of respondents have an antibody deficiency as a diagnosis. The number of respondents was also really high, 747 respondents. And of those respondents, there were a total of 1,169 total pregnancies. And so in looking at how many of those respondents had a pregnancy, there was 71% of the individuals that responded had a pregnancy, and 29% did not have a pregnancy. And that was up to the time. So certainly they could have been anticipating to have a pregnancy later in life. They had not completed their reproductive potentials we saw from the ages that were responding. So what were the outcomes of those pregnancies? So of the nearly 1,170 pregnancies, 67% resulted in a live birth, 25% resulted in a spontaneous abortion. There was terminations in 8%, and it did not, the survey did not tease out if it was an elective termination or a medical determined termination of pregnancy. 1% had ectopic pregnancies. And we see that since some of those, all of those respondents certainly know they have a primary immune deficiency, that's why they're in the IVF community, but they might not have known they had a primary immune deficiency at the time of their pregnancy. So we see that there was some of those pregnancies that were not treated. So the number 1 treatment for antibody deficiencies is Ig or immunoglobulin replacement. And we see that amongst those that were on immunoglobulin replacement and treated for their PI versus those that were not treated with immunoglobulin replacement, there was, although looks like a trend toward maybe more spontaneous abortions in the group that did not receive immunoglobulin replacement, overall the numbers were not significant enough. So the conclusion from this particular study, from the statistical analysis, was that there was no difference in whether or not you were on immunoglobulin replacement therapy, on it or not, and the result of having a live birth or a spontaneous abortion. When looking at the rates of, again, live birth and spontaneous abortion, what was the diagnosis of PI? We see again that since common variable immune deficiency was the most common diagnosis for the group that responded, we're going to see that that's a highlighted number. So roughly 73% in the CVID community had a live birth and 19% had a spontaneous abortion. And I think that's again represented because that was the majority of the respondents, and that's where a lot of the data where we saw a live birth and spontaneous abortion was driven a lot by that group that had CVID. Again, the rest are really the antibody deficiencies. You'll see the SCID in the dark gray. Just highlighted that because those numbers look higher than the numbers for CVID. However, the number overall that responded to the survey that had pregnancies and had outcomes from their pregnancies reported is just really small. So it's a little bit difficult to say if that places the woman and their pregnancy at a higher risk. although severe combined immune deficiency does have other treatments. And again, that might come into management of the immune deficiency and become more complicated than just the genetic diagnosis of the immune deficiency in itself. So again, hard to say what that really meant for outcomes of pregnancy in that particular group. One of the other questions that was examined was for those women that had children and had a successful pregnancy, what happened with those children either early in life or later in life? Were they diagnosed with a primary immune deficiency? Since we're talking mainly about antibody deficiencies, the genetics are not as well known as some of the cellular immune deficiencies can be. We can understand that the heritability of how likely a child may have an immune deficiency much more clearer than for many of the antibody deficiencies. And so not uncommon with how we talk about a lot of these antibody deficiencies, we see that the rates, at least at the time the survey was done, how many children had a PI. So in the respondents, roughly 15% of those pregnancies resulted in a child that they themselves have a PI diagnosis made. And the majority of those PI diagnoses were CVID, because again, that tends to be the most common diagnosis, followed by selective IgA deficiency, IgG subclass deficiency, and then there was a fair number where either the PI diagnosis maybe wasn't certain just yet, maybe there was additional workup that needed, or they were not sure what the diagnosis was. Well, let's flip over to another study because that's a pretty good study we just saw. But let's look at experience outside of the predominantly U.S. population. And this was a report done by the Czech Republic. So I became interested in women's health issues and got involved with the IDF right around that time that survey was coming out and being published. We began to do some work after we participated in that study, had so many questions from that study. And so I've been following the data. And so we took a look at this report from the Czech Republic. We actually work with the Czech Republic in their CVID population for some of our other studies. They did publish their report, and it's their conclusion that particularly CVID, which was really the population they examined, that these pregnancies are higher risk than women without a PI, specifically without CVID. So they looked at 54 women. There were a total of 115 pregnancies that these women had, and 77% of those pregnancies resulted in a live birth, similar to what we just saw. 15% of patients in this study knew that they had CVID prior to their pregnancy. So really a small number, 85% did not know they had an immune deficiency prior to their pregnancy. They found that the number of unsuccessful pregnancies were higher in these women that were not treated for their CVID and were symptomatic at the time. And they also found that there were some pregnancy complications such as eclampsia, preeclampsia, babies born at low birth weight, a threat of preterm labor, and they had a higher number of stillbirths. So their conclusion was that CVID really presented a high-risk pregnancy. So taking those two pieces of information, we set out to do our own report at Duke University, since we've been following patients with PI for many, many decades and had access to a lot of the medical records as a lot of our patients were being followed throughout the decades. And we conducted basically a chart review, but I wanted it to be somewhat contemporary. So we had asked patients that we had access to their medical records and patients that were being followed in my clinic. We had 53 respondents to our study that had really rich data where we could make some conclusions. And so we asked fairly similar questions. We wanted to know what the PI diagnosis was, And we see that the majority of those patients have CVID. Some that responded had functional antibody deficiency, or also known as specific antibody deficiency, maybe hypogammaglobulinemia, and also just IgA deficiency. And there was a total of 117 pregnancies that we were able to study in these 53 women that had responded. Interestingly, I was really interested in the fertility question because we really hadn't gotten to that from the other sources of information. And so I thought we can do a little bit of a deeper dive. We found similarly that 77% of our respondents reported having a history of a pregnancy, and 23% responded that they had never been pregnant. We looked at the outcomes of the pregnancies, and 72% resulted in a live birth, and 26% had non-viable pregnancies, with 2% being terminated. And again, we did not clarify whether it was an elective termination or a medical termination of that pregnancy. And the majority had a vaginal delivery for those live births. Most of our patients, similar to the Czech Republic data, had not known about any PI diagnosis at the time of their pregnancy. Most were diagnosed after they had their pregnancy, completed their pregnancy. And that, again, we know is so common for these disorders where there can be such a great delay in the diagnosis. We found through our questionnaires that the majority of these moms actually were quite symptomatic, but just didn't have their diagnosis yet. Well, we've been looking at a lot of numbers, so I thought it would be important just to kind of reel it in and do a reality check. So these numbers can, are sort of saying we're on the same thing. Roughly 25% do not ever conceive, and similar numbers of about roughly 70 to 75 to 80% of women that do have a pregnancy result in a live birth. So how does this compare to the US population? According to the National Health Statistics, and this they put these reports out every decade or so, and this was completed in 2012. And again, as someone I was really becoming interested in this, so we took a look at the data, and roughly 15% of women complete their childbearing years without ever attaining a pregnancy that they are aware of. And again, from the Immune Deficiency Foundation survey, 28% of women completed their childbearing years without having a child, and our numbers were similar as well, roughly 25%. The national average is approximately 2 children per woman, and from the IDF survey, that was similar, roughly 2 children per woman. So there was no real difference that was noted by having a diagnosis of PI with respect to the number of children that the women had. And actually no great difference with respect to the number of live births to spontaneous abortions. What is a difference is the number of women actually becoming pregnant. And so that raises the question again, is fertility really a concern? And we're going to jump into that a little bit later in the talk, but we're going to come back to that because we have to get through some other health factors, like what's going on with these women, what can we learn about. Every time we're doing retrospective studies and surveys, we never get what the person's really experiencing at that time. It's hard to really know what's going on. And again, we were hoping to get that by doing our own report through our knowing our patients as well as we know them at Duke. And so we wanted to know, okay, were these women, what were some of the medical issues that our female patients had during their childbearing years? What were some of their personal choices at the time? And then also maybe they had complications during their pregnancies, and maybe we could just get a better sense of what the risk of pregnancy is. So in our cohort, compared again to the typical United States female when they are completing their pregnancies. How common are postpartum hemorrhage, a preterm birth, low birth weight, and then non-viable pregnancies. And so we see that for the check data, we saw that low birth weight, preterm births were much higher in that population than they would have expected for their overall national cohort. We did not see that in our cohort versus the US standard. What we did find, what stood out, was actually the use of antibiotics. We found that our patients, and again, a lot of our patients did not know they had a PI at the time of their becoming pregnant and completing their pregnancies. So it would be unexpected that they would have pneumonia during their pregnancy, which is a rare thing in pregnancy. Having sinusitis, which again is not as common in, so the US expected a cohort, as well as urinary tract infections. We know urinary tract infections can be more common in pregnancy, but they seem to occur at a much higher rate in our population with antibody deficiency. We didn't find any particular strength as to whether or not being on immunoglobulin replacement versus not being on immunoglobulin replacement really reduced those rates. They did seem to be high just as a impact of having the PI diagnosis. But then again, we had a small number of patients that were actually on antibody replacement. So maybe we can't make really strong conclusions from that data. I did want to point out, since I had mentioned that non-viable pregnancy is a somewhat high statistic overall for a US cohort at 20% of all pregnancies. And that's where we had seen a lot of our statistics for the both the Czech Republic and the IDF survey, roughly having about the same number. So although it's probably hard to say for sure, it does appear that there is not a higher rate of having a pregnancy loss just due to the fact of the PI diagnosis. Okay, we also took a look at children born to our moms with antibody deficiency. We did find a rate of 6% of those children went on to have a diagnosis of a PI themselves. But more importantly, we found that the young children, whether it be in the first 3 months of life or within the first 2 years of life, had a higher chance of having recurrent infections or requiring antibiotics. The statistic about antibiotics in the first 3 months of life is important because that's where the mom's antibodies would be the sole main protective antibody for the newborn in the first, particularly 3 months of life. So we found that that was a much higher statistic than all newborns within the first 3 months of life. So not to get too dense in the talk, but I just wanted to touch on this real quickly, just to show everyone, were there some factors that affected the decision to conceive? Because we saw that that was much lower. We had asked about fertility and if any of our patients that did not conceive or ever have a known pregnancy, were they undergoing fertility treatment? And we found that overall, those who had never been pregnant had noted that they had fairly significant other health concerns. So in addition to the PI diagnosis, there's other conditions that we see here, GLILD, enteropathy, and some of these other named things. GLILD is just a lung disease and not similar to asthma or chronic bronchitis, but a more significant lung disease, which can make you much more symptomatic. Enteropathy is an intestinal disorder that we can see in PI. Autoimmunity, of course, can be a whole host of disorders like lupus or psoriatic arthritis, for example. And so we found that in those patients who had never been pregnant, it was much more common that they had one of these other health conditions that they were managing at the same time. When asked overall about how they felt about a pregnancy, if they were never pregnant. Did they want to have children? We had a fair number that responded, roughly 36% that said they did desire to have children in the future, but they had some reservations about it, or they weren't in a situation in their life where they were ready for that decision. There were many more that were really worried about their children having similar health struggles that they had. And most women really pointed to a lot of the struggle that they had just getting to their diagnosis, which we know is such an odyssey to get the diagnosis, and all that's associated with that, and just not wanting their child to have to go through something similar. So they had, decided not to have children for those reasons. They're also concerned as well about their own health and whether or not they could care for their children, just due to their own, medical issues. So let's talk a little bit about how do we treat PI and pregnancy at the same time. What do we know about immunoglobulin replacement during pregnancy? Many PI disorders will have a recommendation to use immunoglobulin replacement. Is it safe to use during pregnancy? How does it help the baby? And what other tips, what other things should we be considering? I love this part of the talk because we have so many patients in our clinic now that we've cared for during their pregnancy and have delivered. And if anyone is watching, shout out to you young moms. It's been great. I get really excited. So really, really great. But, it's not really known. And I was surprised that it was not known what to do with immunoglobulin replacement during pregnancy. And so in general, we found that this is the IDF survey again. They found that 75% never had a dose change. So the dose was not increased. It was sort of treated, okay, you're pregnant, you're having this baby, we'll follow you up. But they never had any dose increase, nor did they have their dose more frequently. Some had it more often and did have an increase. 1% of patients had a decrease. And even in our experience, I don't know if it's in here, but we had some women even stop their immunoglobulin during their pregnancy. So just very interesting. We obviously know that immunoglobulin is very helpful. We know that during pregnancy, the immunoglobulin level that maybe you're on immunoglobulin replacement, you become pregnant, all of a sudden what you've been doing is no longer adequate to keep you at your same levels. We're passionate, actually. Always speak to your own physicians. If you're in this scenario right now or in the future, or a family member is, but generally we like to maintain levels a little bit higher, and I'll show you why that is. But immunoglobulin, whether it's your own, made by your own fantastic B cells, or whether you're getting it replaced through an infusion, that immunoglobulin is the same, and it will transfer through the placenta, just like all the other nutrients the developing child is receiving, and no worries about whether or not the immunoglobulin will go to the developing child, because it will. Now, in our own study, we also took a look at whether or not immunoglobulin doses were adjusted, and we found something similar, that 70%, or rather, we found that 20% did not have a dose change, but 70% did, whether it be an increase in how frequently they received their infusions or the dose of the infusion itself was increased. Shockingly, we also had patients that their immunoglobulin was stopped, and that was stopped for fears that it was a blood product, it was dangerous, it would not go to the baby. There were a whole host of reasons. The obstetrician didn't feel comfortable, but the immunoglobulin replacement was stopped. We did also take a look at whether or not the small number of women that we had who were on immunoglobulin replacement, whether that affected the outcomes of birth, live birth, or non-viable pregnancy. And again, we did not see an impact similar to the IDF data. All right, well, this is a big slide, but it's just going to show you one thing, and I'll go through this real fast. I just want to show that this is a level of the immunoglobulin. And this is a woman who is pregnant, who is has a level over here. This is patient through a first pregnancy, patient through her second pregnancy. Basically, as the pregnancy advances, we see the IgG level decreases, the IgG level decreases. For this patient number 2, we see the IgG was fairly stable. The IgG did dose around for patient number 2. This person had a dose adjustment, and their IgG was maintained at a much higher level. The whole point is to show that in this particular article, which was actually done by an obstetrician, actually, it tells us that pre-pregnancy IVIG, this is what this particular group of patients were getting, IVIG, this person got subcutaneous. Really, you don't maintain your levels during pregnancy. There is some adjustment. And this quickly just shows us where the mom is and where the baby is. And this has been really similar to what we have found for trying to track moms during their pregnancy at the time they deliver, and then getting a cord blood sample, because that tells us exactly where the baby is versus the mom. And babies are amazing, and so is the placenta, because they're able to take more of the IgG than we have in they're able to actively pull that out of the mom's circulation, take it for themselves, and they will usually maintain a higher level than mom. So that's why it's so important to keep giving that protective immunoglobulin to the mom so they can give it to their babies. We see this is the baby, this is the mom, this is the baby, this is the mom. And breast milk, similarly, if you're able to breastfeed your baby, there's a whole host of very important nutrients and immune factors outside of immunoglobulin that the child will receive through breast milk. So it's still important for the child, but there will be transfer of immunoglobulin as well through breast milk. So getting away a little bit from pregnancy, to be mindful of the time, I was just going to quickly mention, and we can talk about this through any question if any has any questions, but there are maybe some concerns overall with having a diagnosis of PI and contraception and sexual health. I usually reserve these talks, particularly for young women as they're, exploring their sexual health and having partners, how to keep themselves safe, how to be open with their partner, just how important it is to experience such intimacy with other partners. You really want to make sure that you feel safe and protected, and using forms of some contraception can protect us as well. But I really won't go into all of that, but there are some infections that are particularly of concern in PI, such as HPV, which may certainly lend itself to developing cervical cancer in any woman, but with particular forms of PI can place them at more risk for developing cervical cancer. So at any rate, I just put this up here so we can talk about or take a look at what forms of contraception would be safe. The other thing I want to talk about is menopause. There's no published data on menopause. We are, of course, looking at that as well. We did not note that premature ovarian failure or onset of menopause. I have not really noticed that there's any particular difference in our female patients. We have been following a cohort of our women that are developing bone loss, and overall osteoporosis or osteopenia are diagnoses associated with bone loss. Women in our group had developed signs of early bone loss, on average 5 to 10 years earlier than what would be expected for women without a diagnosis of PI. And so we're really looking into that now, or that's a big question we've had. Certainly medications, other health conditions that are, even without PI, we know what those risk factors are to develop osteopenia and osteoporosis. And certainly in our PI communities, they might have exposures to those medications at higher rates and or nutritional deficiencies from GI issues. So it is something that if you're following with your immunologist or your primary care doctor, we're knowing that we should be doing screening for certain conditions earlier. I think screening for bone health earlier is something that needs to be on the radar for our PI women. Last thing I wanted to talk about was cancer. When I first got into immunology, I read reports about that cancer was much more common in women with PI than in men with PI. Now we know that overall cancer incidence is higher in any immune deficiency, whether it be genetically derived or primary or secondary. There was a study that we participated in. It was a large consortium, the United States Immune Deficiency Network, or USIDNet, and it looked at the development of the four most common cancers or malignancies in men and women, and it broke up specifically by gender. Now we know the most common cancers are lung, colon, breast, and prostate cancer. Now this large study looked at women versus men and looked at the aging population and looked at sort of the US norms versus in the PI communities and concluded that in fact there was a trend, but no significant increase in these particular cancers and having a PI diagnosis. And so of course we're concerned about breast cancer, uterine cancer, ovarian cancer. Really the main concern that we found was the risk of lymphoma, which we've known about for a long time in PI community, that there's a higher risk of lymphoma. And we found, at least in this very, very large study, that relatively same risk for both men and women equally. And this is just how it's distributed. We see that the cancers that were diagnosed from this consortium in women are here in purple, and what would be expected for women without a PI diagnosis. We do see in particular a spike within this age group, and these would be all cancers. We had asked the same question for our cohort at Duke, just wanting to know, I think we had something 250 patients that were in this study. We looked at lymphoma, skin cancer, GI cancers, breast cancer, etc. And we did find that of the patients that had cancer diagnosis in our patients with, in particular, CVID, that there really was a higher female predominance than males for all cancers. And we found sort of a similar distribution that females, again, in that age range, did seem to have more cancers than our male patients. And so, that is, I think the conclusion that we can make from that data is, seeing your immunologist, your primary care doctor, keeping up with appointments. I know it's not always easy to kind of see our faces every 6 months. Doesn't seem like a lot's going on. But there really is, when you get to know your patients and I always call it the spidey sense, like you just kind of look them over and you have a sense, you're thinking about a lot, even if you're not necessarily communicating it. And you're always looking for some signs, some changes. And so keep on your scheduled, routine, recommended surveillance, get all that good stuff done, make sure you're up to date on it. Staying healthy with good sleep, good exercise, stress reduction, and talk to your doctors more about how to do any particular screening, because I don't want to go over anymore. So this is just in summary of everything that we talked about. And I just want to thank everyone for your attention and really welcome any questions.
Wonderful. Thank you so much, Dr. Lugar. That was amazing overview of women's health and how PI plays into all of this. So we now have some time for Q&A, as you mentioned, but before we begin, just please remember that everyone's treatment and condition are unique, and the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. So just want to remind everyone to always seek the advice of your physician and other qualified health providers with questions about your medical conditions. So with that, we had a lot of great questions come through. One of the most upvoted ones is, do you feel that most OBGYNs have knowledge of PI? And how do PI patients make sure that they get this information to their OBGYNs?
Yeah, that's an excellent question. What I didn't show was some data about that. I think it's getting better. I really do. At least in my little microcosm, I do feel like it's getting better. And a lot of that has come from, I think, patients advocating for themselves. Like, whoa. We talked to my immunologist. And I think that has sort of trained them to say, okay, this is different. I don't feel that the majority are very comfortable with many subspecialists with anything immunology. And that's okay. Like that, that's okay. Like that's, we're all on a mission, to increase awareness. If you do not have support, don't sit on it. The IDF has great resources. I think there's like a call a doc program, and, get in touch with an expert. Most of the folks in the practitioners, I think in this field are just really, we're here to help, and anything that we can do to help. So, get support. If something is registering with you, if you need more information, if something doesn't sound right, pursue it, because you don't know what you don't know. And I think a lot of times physicians, meaning well, like they'll be able to, really get you through that complicated delivery. I certainly could not when it comes to the immunology, like make sure that, you have a team, and that's gonna serve you well.
Great, thank you. So another one that we have is it true that IG levels or IG needs change during menopause? Is there data about, should people take precautions as they get older and go through menopause?
Yeah, so in my next life, I would love to study that, because I'm really interested in there's a field called immune senescence, which essentially means the aging immune system. And I'll just briefly say that the female, I actually had a slide, but I took it out because I can just talk forever, but the male and the female immune systems are really we're just geared very differently. It's why you hear autoimmune disease and much more common in women. Women are going to be more sensitive to medications, medication doses, have more allergies, Well, because we have a different immune system, and it's triggered a lot differently. And the old saying is that, this is when I was at the NIH, when you go into menopause, your immune system begins to replicate the immune system of the male. And we know that from vaccine data, like how strong your immune system responds to a vaccine and how old you are. And it's like, oh, men and women finally equal each other past menopause. But I've not found that to be any relationship, at least in like a large number where I can actually say, this is a thing. I've not noted that happens as a general statement with requirement of immunoglobulin and menopause.
Another really interesting question is someone said that as someone with PI hoping to get pregnant soon, you talked a little bit about how some women change dosage of their IG when they're pregnant, some stopped treatment at all. Is there any IG dosing needs that need to change as your body changes when you're pregnant? Is there any reason that you should be changing your treatment or how frequent you're getting your IG?
Excellent question. Yes. So there's two factors that are small factors. One is just a change. You do more fluid retention, and you have these proteins that your liver makes that binds proteins a little bit differently. That's a small factor. Then there's weight gain. So those are small factors that might dictate that your levels are changing. However, the biggest change, the figures that I showed, actually has to do with the developing pregnancy. So the placenta actually changes, and the placenta changes, and new cells come in, and they're called syncytiotrophoblasts, and those particular cells are capable of drawing the immunoglobulin out. That occurs at about 28 weeks. peaks really at about 32 weeks and beyond. And so most of the immunoglobulin shifts when you see it drop, like we see, and this is our data as well, we've seen it again and again and again. Right as soon as you hit past 28 weeks, you're going to want to get your levels checked more regularly. We usually do every 4 weeks so we can stay on top of it. 2 reasons why I want to do that. One, I don't know when you're going to deliver. When you start to get to 30 weeks, 32 weeks, I don't want to say, okay, let's get you back to a good level that I feel comfortable with next time I see you, because you could deliver in that time. And that means that your child might be at 750, but we know you're going to be at 500 and you have to not have postpartum infections. We don't want you to get mastitis, and you've got to go through a lot still. So yes, we want to keep your antibody levels up to what keeps you healthy. We know we're going to have to pay higher attention to that, right? Beyond 28 weeks, because we know your levels are going to usually drop at that time. We know your baby is going to prefer to take away from you. And we just, so those would be some of the key timings and the key reasons. And of course, we want your baby to have good antibody. If you're one of those patients that really doesn't have any natural antibody you make, it's all coming from your infusions, then yeah, we want to make sure that your young child also has a good immune defense. And that's going to come from what they can get from the cord blood through you.
And I think we have time for one more question here. And I think this is a really great note to kind of leave this session on. Dr. Lugar, you talked a lot throughout your presentation about how there really is kind of a lack of data and a lack of information about women's health and PI, and how, all of those different factors go hand in hand. So we had a few people ask, how can we support the creation of additional data? Are there things that individuals in the PI community can do? How can we kind of up the information that we have on women's health and PI?
Yeah, well, I think going through, there are many ways to do this. One is, I got a great idea from talking to a patient a number of years ago who asked me a question, and I thought, what an odd question, and then it sent us on this whole research endeavor, which was amazing. So, even though I know we're like super busy, and, it does go somewhere, when patients talk to us, it really does. We have a lot to get through in that visit. We've got a lot going on internally that we're trying to get through too. But yeah, so asking the questions to IDF. IDF does sponsor research. And if they get enough, I think that if they get enough interest from patients that that they're interested in certain questions, then, when we as researchers are writing to the IDF saying we want to do a survey or we want to do this research, will you help support us? The critical reasons why we can't get a lot of these questions answered are, funding. Everything that we do, particularly at academic centers, does need to be funded. So, there's grassroots efforts for funding, there's IDF for funding. If you know of any organizations, I had another patient who got an award, and their company sponsored a research project. And so, there are some things that can be done, and patients can get together and ask questions, and, find an interested physician. Sometimes you'll work with fellows that are working with attendings at academic centers, and that might be a way to see if a fellow might be interested in taking on a project just by talking to them. Like, has anyone looked at this? And, talking to your doctor about what could we do to actually get this question answered. You guys have great ideas, and I really do think that it needs to be shared. Everything gets done a lot better in a community than it does on your own.
Absolutely. I couldn't agree more with that. And, our time together is unfortunately coming to an end, but just want to remind everyone, as I said, we had so many great questions come through that Q&A. So if we didn't have time to get to yours, remember that, Ask IDF is always there. So if you ever want to reach out to us about, any of these topics that we were discussing, or have questions for, physicians that we may be in touch with, please, go ahead and submit those questions to Ask IDF. And it really has been an honor to have you with us, Dr. Lugar. Thank you so much for joining on and having this conversation with everyone. Just as a reminder, we still have lots of sessions left this afternoon for the PI conference. So we hope you continue tuning in, and just want to thank our sponsor, CSL Behring, again for supporting this learning opportunity. And with that, I will say goodbye. Thank you everyone for joining us.
Thank you for having me. Bye.